of the sphenoid, and then it runs and supplies this nasal septum. So to harvest this flap, we must first preserve the pedicle. To preserve the pedicle, our first incision should be just below the ostia of the sphenoid here.
Say. Ektu.
And flap or not. Best practice is to give an incision here. Right, so this is what we call as a rescue flap. Rescue flap is what? If needed, you can convert this rescue flap into a complete head-on flap. Okay, you preserve the pedicle, you give this incision, and you retract the pedicle down, all right, away from your sight, all right. So you retract it down, and you are ready to do your bony work. Okay, and from here you do a posterior septectomy. And you do opposite side.
Paisi dia botol tu, boleh ambil ke? Hello. 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 Hello.
बॉडी से सेवलम का बॉटल इधर एनाटॉमी डिसेक्शन हॉल में लेके आना है, ठीक है?
হ্যালো 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 তো তোমার যাইতেছে না কথা বলে যাইতো না কথা কইতে লাগবো হ্যালো আচ্ছা ডাক্তার হ্যাঁ হ্যালো স্যার অবস্থা না আচ্ছা এটা লাগাই দিয়ে স্যার
So now the landmarks are coming clear. Hello, are you able to hear now? Okay.
হ্যালো 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 প্রণব আমার কথা শোনা যায় তো হ্যালো হ্যালো হ্যাঁ হ্যালো ठीक है तो सर नहीं इनकी आवाज नहीं जा रहा है तो बोला था हेलो मेरा आवाज आ रहा है क्या अरे तो
ये चेंज कर दो
जुड़े को चला
Hello.
नीचे तो
चेंज कर दो ना
चेंज कर दो হ্যালো 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 হ্যাঁ আমার কথা আইতেছে নিচে লাগে লড়া এই কাছে আসতে করতে লাগে
Sir, it's loud. Am I audible now? Hello. Is it clear now? Is it clear now in the auditorium?
Hello.
Is my voice clear?
Hello. Hello.
हो रहा है अगर पॉसिबल है तो.
Hello. 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 Hello.
Hello. Is it audible? I am Dr. Karnajit speaking. Is it audible now? Okay, just a minute. Okay. Just a minute. Where's the link? ऊपर लगा ये नहीं इसको लगा दीजिए.
Hello. Am I audible in the auditorium now?
Yes.
Okay. So thank you. So, स्मॉल प्रोब बेटे, स्मॉल प्रोब. एक बार वॉश दे दो. वॉश दे दो. वॉश. दैट्स ऑल. सक्शन नहीं चल रही. टिप ब्लॉक. ओके. इज द पिक्चर क्लियर देयर? let me Okay, sir, what is this? We have done a left side full house fess. We have opened all the sinuses. I can orient you again. So that's the maxillary sinus opening, and superiorly we have cut this middle turbinate here. That's the sphenoid sinus. Tar hil gayi. All right, so that is the anterior ethmoidal artery, posterior ethmoidal artery. That is the sphenoid planum, that is the tuberculum sella, that is the proper sella. So that is the paracavernous carotid on the left side. Alright, so this is the orbital apex. If we follow the orbital apex, we get to the optic nerve, which is here. So on the right side, that's the optic nerve on the right side, and this is the paraclinoidal carotid on the right side. Are you oriented now? Hello, are you oriented in the auditorium now? Hello? Okay, give me Carrison. So generally this sella is where our pituitary gland is, alright, and in pituitary tumors this sella is enlarged, and many a times the bony wall over this sella is completely thinned out. Alright, so in a normal case this may be thin, but in a pituitary tumor case, Carrison, you may not need to drill it. So here we'll try to see the weakest area and we'll try to drill this out. It's quite hard again, so I'll try to find out the weak area and make a opening so that I can reach with my Carrison. Okay, so this structure that you are seeing is pituitary now. Alright, so I'll try to make a opening here with the Carrison. So because this is the only instrument that is available to us, and you extend it superiorly. 1 number Carrison hai?
Other
Yeah.
than the Carrison, what can we use?
You can use an elevator, you can use a drill. Yes. Give me suction now. I'll mention. I'm coming to that, okay? So this is your pituitary gland, okay? Give me straight suction now. See that it is covered by dura. Pituitary is a, it is covered only by the outer layer of dura. The subarachnoid space does not extend into the pituitary. Therefore, if we do a routine pituitary surgery, we don't get a CSF leak. It is only if we go superiorly and we puncture the arachnoid, we'll get a CSF leak. Now, how much bone should we remove? All right. So, ideally, we should remove from one carotid to the other carotid. Okay. Superiorly, we must remove from this. There is a superior intercavernous sinus here, just below the optic chiasm. From the superior intercavernous sinus to inferiorly to the inferior intercavernous sinus, and we must remove whole of this floor of the pituitary. Okay. So now I'll try to remove this and expose the Sellar and the suprasellar structures for you. Carrison. So please bear with me because it's a big Carrison and okay. So that's the Carrison. You engage your Carrison to the bone and you can just pull out the bone in a real life, okay? So avoid taking punch when you are near to a important structure. Okay, I'll repeat again. So like we have to remove a bone laterally, this is a big Carrison. So like here, okay? So you engage your Carrison and just pull it. Thin the bone with the drill and avoid taking a punch like this, okay, in a real life situation. So
In life surgery, this instrument is best for removing this one.
in live surgery, it is first best to drill out this bone, to thin the bone. All right, once the bone is thinned, you can easily take it. बेटे wash कर दिया करो जैसे ये आ जाए ना, wash it, right? You can thin the bone with the you can remove the bone with a simple ST elevator and with the Carrison like I mentioned, okay? So this is our carotid now, and this is our lateral limit on the right side. Similarly, we can remove this bone till this is our carotid here. All right, so these carotids, this is the cobra, these two form the cobras of the carotid, okay? Like a hood of the cobra. So between these two carotids is our exposure. Okay, so now Carrison again. देखना suction level. Okay, so I'll try to remove on this side also. Okay, right? Yeah, so when you are close to the carotid or any vital structure, avoid punching. Here I am punching because I don't have any other instrument. All right. So, and you can extend it superiorly to remove this bone from the planum. This is planum, okay? I'll show you. I am removing this bone from the planum area also. Clean it. Sellar is exposed. So I am exposing the planum now. All right. So that's the planum area. So planum transplanar approach is very important in cases where there is very huge tumors, pituitary tumors, which have significant suprasellar extension. Remove. All right. In craniopharyngiomas, in suprasellar meningiomas. Right. So this approach is very important. Okay. Give me 4 steps.
this forceps is not holding. कोई और forceps ले लो. Okay. Now see the structures. Give me a probe now. छोटा probe दो बेटा, ये इतना बड़ा नहीं अभी. When I say probe, when I say long probe, give me a long probe. When I say probe, give me a probe. Okay? So this is pituitary now. Okay. So this is optic nerve, right? Optic nerve on the right side, optic nerve on the left side. So this is dura. See the dura? I'll remove this dura, right? And posteriorly, what you can see this? See this thin layer? This is arachnoid. All right? See, so till we open this arachnoid, we'll not get a CSF leak, okay? Now, if we, whenever there is a pituitary tumor, you just give an incision in the pituitary tumor, take a biopsy, and most of the time the pituitary tumors are soft and suckable. All right, so you just suck the pituitary tumor gently from the sella, and if there is a little bit of firm component, you can use 2 suctions, you can use ring curettes, all right. So you will be able to remove the pituitary tumor. All right, so that is how the normal pituitary looks like, right? So that's the dura and that's the pituitary gland. Okay. Now I'll clear a little bit more. Give me a comparison again. So yes, first of all, you try to identify it on a CT scan. Okay. In the intraoperatively, you can identify it by the color. Now coming here, can you see some very important structure? Probe. What is this? See the optic nerve coming here and the optic nerve coming from here, and they are joining here to form the optic chiasm. Okay, so this is optic chiasm. All right. So optic chiasm lies little superior and posterior to the pituitary. Garrison, I'll try to clear this more tissues for give you a better clearance. Yeah, no, I'll do with the Garrison only, right? So that is not an endonasal drill. All right, so I'll just clear this so that all of you have a better view. Give me suction and a wash. Suction, आगे डाल दो wash. All right, that's all. Right. Yes. So in real life, sir, it depends. In pituitary cases, we generally don't try to see the optic chiasm. Our focus is on the tumor only. We remove the tumor, but many a times after removal of the tumors, we can actually see all these structures that I am going to show you now. Okay, give me sickle knife now. Now a very important structure coming out now. Sickle knife. So see, this is pituitary, and if I retract this, so right, so posteriorly here, I'll clear it, you will see the pituitary stalk. Okay, I'll clear and show you the pituitary stalk now. Can you see the stalk? So that's the pituitary stalk, okay? You see these small perforators, small vessels. All right, so these are very important vessels. In real surgery, we must do everything not to injure these vessels. These are the vessels, branches of superior hypophyseal artery. They supply the pituitary, they supply the pituitary stalk, and even they supply the optic chiasm. So if we injure this, The patient may get blindness, the patient may get pituitary hypofunction. Okay? Now give me sickle again. Sickle knife again. Now, so what happens when the tumor grows, pituitary, the tumor in this gland grows, it causes pressure here. Alright, it causes pressure to the optic chiasm and the patient gets bitemporal hemianopia. Alright, so it may cause stretching of the optic chiasm. Alright, so optic chiasm goes up and gets attached to the hypothalamus. Right? And if we go superiorly here, alright, superiorly here you will see our third ventricle. Here, can I get a curved suction please? So, large tumors extend superiorly and go to the third ventricle. I will try to show you the third ventricle also. So, if you do this, all right, so there, see the CSF coming now, okay? Yeah, so this is pre-chiasmatic cistern, all right? If you open here, there is a huge cistern here which causes huge CSF leak, okay? And one, again, very important structures, probe. See. Can you see these blood vessels? This vessel, so they are anterior cerebral arteries, A1, all right. So it is getting communicated with this is the anterior cerebral on the right side, this is anterior cerebral on the left side, and this is ACOM, anterior communicating artery. All right, so these are very friable branches. Even if we do mild instrumentation, suctioning over these branches, they can go into spasm. And the patient can have symptoms. So this is a very, the tumors like meningiomas, like craniopharyngiomas, which arise from this area. So they are very risky tumors. Pituitary is the safest tumor to remove, but craniopharyngioma may arise posterior to the chiasm and get attached to the hypothalamus. All right, and they may have supply from these vessels. So that is what makes them very risky, removing these tumors. Now give me a suction again. Yeah. So just I'll take another 10 minutes. I'll show them the cavernous sinus anatomy maybe. Okay, so you give me sickle now. You see, if this, I told you this is our carotid, okay? So if you remove this, you will see the cavernous carotid here. And the carotid will be dividing here, okay, into the middle cerebral artery and the anterior cerebral artery. If I dissect, see the carotid? See, that's the carotid, okay? And the carotid is dividing. This inferior branch is middle cerebral and the superior branch is anterior cerebral. Can you see? Yes. So, and if the tumor goes superiorly here, if you go superiorly here, you can see the third ventricle, you can see the foramen of Munre, you can see the mammillary bodies, all the structures here. Yes, so if I lift this, just wait, I'll go from inferior. If we try to lift here, you will be able to see the third ventricle there. Alright, so suction डाल नहीं पाएगी वो कोई बात. So that is the third ventricle and that is the mammillary bodies on the right side. Okay, so I'll go with the suction. I'll go because you won't be able to put.
Should I do all together?
No, it's okay, I'll do. You see, so that superiorly goes to the third ventricle, okay? So that radiation, that is optic radiations. Straight दे दो.
Straight section ले लो.
हाँ सब दिखेगा इसमें.
is better than
Right, so that is optic radiation. Can you see the mammillary bodies there? And that's the third ventricle. See, my suction is in the third ventricle. See, this is all CSF. Can you see the foramen mundo and the retinoid granulation tissues? See the lateral ventricles. Inferiorly, that is the aqueduct of Sylvius. And now a little bit about the cavernous sinus. Give me Carrison. दिखा दूँ? हाँ बस ठीक है, right, okay. So if I remove this bone, I'll try to remove this bone and go laterally. See the carotid here? All right. So carotid is the one of the constituents of the cavernous sinus. I'll just show you, right? So I don't have a down biting, so I'll try to remove this here. Yes. All right, so that is my cavernous sinus now. All right, give me some elevator. So that is the carotid, right? So when the tumor goes laterally into the cavernous sinus, we need to remove this whole of this bone from the carotid. Okay, see this bone from the carotid and go laterally to the carotid. Now the carotid lies in the medial compartment, okay, and in the medial compartment of the cavernous sinus, see this is a venous filled space. All right, see the venous filled space, that's we are inside the cavernous sinus. In the medial wall of the cavernous sinus, there are nerves. All right. Superior most is the third nerve. All right. So we will be able to see the third nerve. Give me a fine probe now. Lamba nahi, chote wala. Haan. Let me see if I can show you the nerves. So somewhere here lies the third nerve. I need to remove this bone a little maybe for the proper exposure. So this is what? Superiorly this is what? Optic, okay? Yes, this is optic. So this is opticocarotid recess, okay? So opticocarotid recess is formed by the clinoidal process, anterior clinoid process, which is a part of the sphenoid bone. I'll remove this bone a little more. So what I am opening now is the cavernous sinus, and this cavernous sinus leads anteriorly to the superior orbital fissure. Okay. So from the cavernous sinus, all these nerves pass into the orbit through the superior orbital fissure. So this is cavernous sinus, and you will see all the nerves here. All right. So running superiorly is the third nerve, then inside is the fourth nerve, sixth nerve is the longest nerve, that lies a little more laterally. All right, then inferiorly we have V1, and just below the cavernous sinus, at the floor of the cavernous sinus, we have V2, that is maxillary sinus. So to V2, we identify V2, we must go transpterygoid. Right, transpterygoid, we remove the posterior wall of the maxilla, we trace the infraorbital nerve. infraorbital nerve continues posteriorly as V2, all right, and then it goes into the foramen rotundum to the inferiorly the cavernous sinus, and inside there is all these V1, V2, V3 forms Meckel's cave. Okay, so give me elevator. And inferior to the infero-medial to foramen rotundum lies your Vidian nerve. All right, Vidian nerve runs in the floor of the sphenoid sinus, and it goes interiorly to the apex of the temporal bone at the level of foramen lacerum. All right, here. So if we want to reach the foramen lacerum, we must follow the Vidian nerve, and we will reach the petrous part of the carotid artery at the level of the foramen lacerum. So, okay, so one more thing, if I remove this bone, right, so this is clivus, okay, so in transclival approaches we need to remove this bone, okay, for that we need to remove this floor of the sphenoid sinus also. If we remove this bone, we will be direct at the clivus, and here you will be able to see the basilar artery. If we lift this pituitary here, you may be able to see the basilar artery here also, right? Freers. So if we lift this,
Yeah, you can see the there.
yes. So just wait. Yes. So this vessel, see the basilar artery, right? The basilar artery divided into posterior cerebral. Okay, so that is the posterior fossa here. Okay, so that is the approach. You can go to the lower clivus, drill all this bone, and then inferiorly you can go transodontoid also. So you can do transodontoid. And in cases sphenoid sinus is pneumatized laterally, very laterally. It pneumatizes the greater wing of the sphenoid, right? It forms a lateral recess of the sphenoid. All right. So sometimes there is a leak in the lateral recess of the sphenoid. So to repair the leak in the lateral recess of the sphenoid, we cannot go directly transsphenoid. Sternberg's canals, yes. Yeah. So then we have to go transpterygoid. So advantage of the transpterygoid is you can reach literally till the middle cranial fossa from the transpterygoid approach. But there is one disadvantage of transpterygoid approach. When you are doing transpterygoid approach, you have to clip the sphenopalatine artery. All right. So you cannot use the Hadad flap on this side to repair the skull base defect. Whenever you have to go transpterygoid and you may feel that there is a need to repair, always take the flap from the opposite side, because your pedicle will be compromised when you go transpterygoid. Okay, so doing the transpterygoid will require another half an hour for us to do. Yeah. Okay. Okay, I can show you the sphenopalatine artery. So, yeah.
We are left with 10-15 minutes. We can show further approaches to them.
So yes, I'll just show the sphenopalatine artery. Okay? To see the sphenopalatine artery, you must identify where the middle turbinate is getting attached posteriorly. See, that's the middle turbinate getting attached. You just 1 centimeter anterior to the middle turbinate. Okay? You give an incision and you raise this flap. You see some bone coming up, that's the crista, right? So that is crista of the sphenopalatine foramen. So that is your sphenopalatine foramen. Okay? Give me Carrison. I will show the artery. Yeah, I'll show the artery. Yeah.
And this artery also gives off a branch.
All right. So if I remove this bone here, maybe I will be very fine. I'm not able to engage.
You can show that by elevating the muscle.
Yeah, मुझे वो दे दे, ये कैरिसन ही है. मुझे वो दो कुछ एलिवेटर या क्यूरेट दे दो, जेक्यूरेट दे दो. All right, see, approaching, how easy it is to approach the sphenopalatine artery. You see, so that is the, can you see the foramen? And that is the sphenopalatine artery. See the foramen. This sphenopalatine foramen is formed by the palatine bone here. This palatine bone forms two recesses, anteriorly the sphenoidal process, posteriorly the maxillary process, and superiorly this is closed by the sphenoid bone. Okay, so this is the sphenopalatine foramen. Now you see the sphenopalatine foramen here completely. Okay, so that is the artery. Okay, so you can, if you keep on removing this, you along with this you remove the posterior wall of the maxilla, you can identify the maxillary artery. You can trim the maxillary artery, like we clip the maxillary artery like we do in our angiofibroma cases. So anything else, boss, you want to? Okay. So I can do, it will take minimum 15 minutes if you want. All right, thank you, sir. Huh? If the time permits, as you, अगर time हुआ तो फिर कर देंगे. So I'll show you modified Dankers if the time permits, and the transpterygoid.
হ্যালো হ্যালো কাকু হ্যালো প্রণব কাকু হ্যালো 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 হ্যাঁ পাইছি পাইছি আমার পাইছো অডিবল ওকে ওকে
हेलो इंस्ट्रूमेंट निकाल दो हेलो 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 ऑडिटोरियम anybody listening? Hello, audible. Okay, so we are going to have our second session which will be on lateral scalways. I request all the participants, mainly dissectors and observers, to come here and take part in the dissection. We are going to start in a moment. ইনস্ট্রুমেন্টগুলো রেডি কর, সব 5টা টেবিলের ইনস্ট্রুমেন্ট রেডি করে কি বানাচ্ছিস? এটা তো হয়েছে, ইনস্ট্রুমেন্টগুলো তো রেডি হয়নি। কাকে দিস না 5টা টেবিল বানাতে লাগবে না?
ব্যাটারি হাফ
আরে আমি আসছিলাম না
বেশি ধাক্কা দিলে তো আমার মেশিন আছে
না টান না
না না না না না
কত আইব কত আইব তাহলে একটু সোজা করে
এই ধাক্কাইস না
আপনি আপনার বাস ছেড়ে দেবো এটা সাবল দাব দিয়েছি
ड्रिल अभी क्या हो गया कुछ कीबोर्ड का ये प्रॉब्लम हो गया तो मेरा थोड़ा सा बैंडल था ना जिससे हम लोग ड्रिल लेते थे हमने बार नहीं मिल रही थी तो हम लोग को मैनेज किया
लिए लिया है ऐसा ना तेरा हाथ में वो लगा होगा तूने कुछ टच किया इस हाथ से फिर वही लगा रहा है फायदा क्या हुआ साला फिर तो मैं ही पहन लूंगा जाके फिर तो मैं ही पहन लूंगा आवाज आ रहा है क्या ऊपर कौन मॉडरेट कर रहा है लगा दे कैसे हाँ यूं पहन हाँ ठीक हाँ हेलो Are you getting the picture? No, इसको आगे लाना है ये उड़ाओ ये इसको खोलो लॉक्स लॉक 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 लगा हुआ है लॉक लगा हुआ है Are you getting now? It's easy for you now. Huh. It's good picture there. Hello? It's good picture? So, yeah. So that cadaver is a bit rotated, huh? What is it? Leave it, leave it. It is not for there. No, you don't have to do anything with it. Only here. You have got this control. Look. So, what we can discuss today in lateral skull base, right from mastoid exploration, that is cortical mastoidectomy, then we'll go for an intact canal mastoidectomy, we'll explore the labyrinthine block, then we'll see for the endolymphatic sac, posterior fossa dura, middle fossa dura, and once we have labyrinthine block has been explored, I'll show you the posterior tympanotomy and then the way to do a cochlear implant through the posterior tympanotomy. Got it? Then we can do a labyrinthectomy, and with labyrinthectomy then we can explore the interacoustic canal. So intact canal we will be doing this all. Then I'll show you the external acoustic canal lateral temporal bone excision in CA ear, which is involving only the external acoustic canal. So we'll do that. Then we'll do the canal down, and after that cochlear route, and if time permits, infratemporal fossa type A approach. Got it? This is all we are going to do. Okay. So we'll start with the incision. So you know the classical William Wildes incision. What is that? Right from the post-auricular groove up to 5 mm in the posterior part, 2 mm from the superior attachment of pinna, 2 mm from the inferior attachment of pinna. You make an incision like this. Got it? But I'm not going to do that incision, William Wildes here. Why? Because we are also exploring the whole mastoid, the sigmoid sinus, and we want to explore, we want to do infratemporal fossa type A. So my incision should be more because I will be also exploring the neck vessels. I'll show you the neck vessels in continuity to till here. Okay? So for that, most of the people, even Yugofish used to use an incision which was like, this is your mastoid tip. Can you make out? So from mastoid tip down there, you come like this and go like this. This was Yugofish technique incision. But what Dr. Sampath Prasad does, he takes a different incision. He takes an incision like this, and then he curves it there in the neck. Got it? But I prefer taking a Yugofish incision right from the hyoid, level of hyoid. I come posteriorly and then I go like this till there. And if you want to take the muscle and fascia along to reconstruct the cavity, you can move it like this in the hockey shaped incision. Got it? What you will do is, you will move this like this, hockey shaped. Got it? So that you can get a lot of temporalis muscle based anteriorly on superficial temporal artery and can move that and fill the gap there in the mastoid cavity. Okay? So now, forceps, don't use a tooth in a live patient like this on the skin. I never use a tooth forceps on the skin. A non-tooth should be used. Got it? So we'll elevate a skin flap only. We leave the muscle down there. Can you make out? Yeah. Can you make out the areolar tissue over your temporalis fascia? So you could see the temporalis fascia there, go further down there. Your knife should become horizontal here, got it? If you make it vertical, you will injure the musculoperiosteal flap, which should not be injured. Then move it a bit inferiorly in the neck. Here you have to be superficial because you can see your sternocleidomastoid is coming in view. I'll take it further down there. Got it? And I'll elevate it like this. How to retract it now? Can you see this avascular plane there? Leave this sternocleidomastoid down there. When you elevate the flap, don't take muscle along. Leave the muscle there. But here you have to take a subepineuritic flap, like the way you do a parotid now. So for parotid, as you take submusculoepineuritic plane, got it? Smash flap. Look where I am going. I am leaving this. Yeah. Yeah, I'll centralize. It's seen now? So it is smash. You look, can you see the platysma there? So I am going subplatismally. And you go by the smash flap, this, like this. And you see the parotid there? This is your parotid. Got it? Down there, sorry, this is cut a bit because I want to show you the parotid there. Oh, it is adherent there. Got it? So there you see the parotid. We'll show it later on with the facial nerve continuation. And now you go further because any skull-based surgery you will have to go for a cul-de-sac closure. For doing a cul-de-sac closure, you have to elevate it. No, it's okay. नहीं स्टूल ऊपर तक आएगा कहाँ? Further you are going. So I am going till the canal. Now if you see, you have reached to the canal. It is bleeding. The cadaver is bleeding somewhere. So now, what about the muscular flaps? Musculoperiosteal flap. If you talk about simple tympanoplasty, I never take a Palvas flap. Why? A Palvas flap is anteriorly based flap. A Portman's flap is posteriorly based flap. If I take an anteriorly based flap and suppose I have to convert this tympanoplasty to mastoid, canal down, you will have to cut that flap when you are doing a myotoplasty. So you will be sacrificing that precious flap. So don't ever elevate a Palvas flap, I would say. In the cochlear implant, also they elevate the palvas flap. But what we have started doing in cochlear implant, me, Rajiv, Amit Kesri and Dr. Amit Goyal there at Jodhpur, at AIMS, we elevate a superiorly based flap, which is based on the superficial temporal artery posterior branch. So we elevate like this, got it? But when you are doing a skull based procedure, you keep it intact on the occipital artery. So it should be inferiorly based flap like this, and you can use this flap along with that flap to fill the cavity. So you have got anteriorly based flap on the superficial temporal artery. Can you see the artery branch? Can you very well see, made out the branches? Okay, posterior branch of the superficial temporal artery. And here it is based on the occipital is going deep to the sternocleidomastoid, deep to the mastoid, and anterior to the jugular tubercle. It is coming behind the posterior belly of digastric and curving behind, and then it is supplying this musculoperiosteal flap. So if you keep it intact, this will be well supplied flap, and this will be well supplied flap anteriorly based. Both the flaps can be used to fill the cavity. So in this case, which we'll take inferiorly based flap. We'll elevate an inferiorly based flap. Okay. So it should be bone deep like this, go like this, come superiorly, come like this. Now stop there. When you go, you drop down this incision. What structure you will be encountering during your incision there would be mastoid emissary vein that comes when you elevate it. It comes when you are doing a cochlear implant also, because you are elevating this flap. So when you come down, you will be seeing, I'll show you that. Okay, elevator, hold it. Can we sew it there? I'll show you. Suture hai? Nahi hai. I'll show you the cul-de-sac later on. How do you do the cul-de-sac? Okay, I'll show you later on. So, Farabaugh, elevator, musculoperiosteal elevator. Can you make out the blood? This is the best cadaver you do have. That's why that girl was lucky to have such a beautiful anatomy inside the nose. Okay. So you have to be like very cautious when you are going there. Can you make out veins there? So this could be the emissary vein there, or maybe some below. Elevate it, cut it further, or use a cautery so that you elevate it properly. Rajiv, correct me if I go wrong somewhere.
Say something because we won't do any mistake.
Do
some mistake, then I'll speak something.
That your cochlear implantation when I'll do, then this will be a problem. So here I am elevating, and you can see something coming, some bluish structure. Can you see? So this is the posterior mastoid emissary vein. Can you make out this vein? This is the mastoid emissary vein which comes. So you have to be cautious when you are elevating it down there. I am elevating it off the mastoid tip as well, so that you see the structures there. Got it? I'll make a cut there so that you see the things properly. Couldn't get it. What was that? I always elevate an inferiorly based flap, because if I want to do a mastoid and if I want to make it a canal down, what I'll do is it would be inferiorly based flap, and I'll remove the mastoid tip lateral to your facial nerve, stylomastoid foramen. So this whole muscle will be coming in the mastoid cavity, make it short cavity, a small cavity. So that's the basic reason I do it. And most of the times I reconstruct the canal wall. So I rarely give a canal down. Got it? Now some more exposure there. Here, your temporal line, can you make out the temporal line?
Yes.
Okay, and then elevate it anteriorly. You see the spine of Henle coming in view. Elevate it further, and you see the spine of Henle. It has come. Can you see this spine? I'll show you like this. Look, this is your spine. Okay, there is a lag between my hand and the video there. There is a lag. Look, you look. I'll let you. There is a lag between what I'm doing. I'm already reached there. Then it comes. There is a lag between the transmission. Yeah. So I'll focus it, and to make a cut in the external acoustic canal, a small knife is there. Okay, I'll take a D knife or maybe a stab knife, that is 11 number. So what you do is, for juniors, elevate this flap a bit more like this. Okay, keep your knife at first horizontal on the spine, then around 1 to 2 mm immediately push it like this. Got it? Lower it and then stab. After stabbing, take it like this, like this. This is what I love doing. I take a lateral vertical cut here and take a lateral vertical cut here, so that your retraction becomes very easy. Okay? Give me a mastoid retractor if you do have. You have? Okay. So I'll be using a mastoid retractor now. It's Mollison's toothed hemostatic mastoid retractor. Got it? Suction, because it has got wax inside. I'll do this thing. It is well seen there. There is some lag. There is some lag. तेरे टाइम नहीं था. Guys, people. So at first what I'll do is, I'll start drilling the mastoid antrum. One more retractor if you have. One more retractor. So if you see any instrument, if you see, this is cribrosa mastoidica. Got it? This cribriform space, air cells are coming in view. You start doing there. McEwen's, you delineate the McEwen's triangle and start drilling the mastoid there. Got it? It's not properly placed. No, उसको तो ठीक है, वो तो ठीक है, उसको और कर लो. Otherwise, I'll remove the whole soft tissue. हाँ, soft tissue को उड़ा दूंगा. ठीक है, इसको अच्छे से लगाओ. अरे, सूचर मार दें क्या? You don't have sutures. Sutures नहीं है? चलो रहने दो. अरे नहीं हो रहा, राजीव कपिला. छोड़ देता हूँ, चलो इतना. यहीं से ले लूँगा ऐसे, है ना? I'll make it further. I'll make a further cut there. I'm just cutting it for the sake of showing. Don't cut it like this in the live patient. Keep this flap intact. Got it? Okay. Drill. Water. section. So, if you can make out what is McEwan's triangle? Yeah, it posterolateral wall like this. You delineate, you make a line like this, come along the superior, the temporal line, and join them like this. Got it? So this makes your McEwan's triangle. Can you make out? This makes the saline jar डालो ये सब. You should collect this bone dust. Why? Initially you should do what we have done. Less of saline, more of drilling, and collect this bone dust with the Freer's elevator. Take it and on the corner of the bowl, just keep it there so that whatever wet water is there will precipitate down. And this bone dust can be used to fill the crevices in the mastoid. When you do an intact canal or maybe a canal down, small crevices would be there, which would prevent a smooth lining cavity. So you can fill those crevices with this bone dust. This is very good because it belongs to the patient itself. And it is sterile. It is not infected. But if it is a case of a subperiosteal abscess or a mastoid abscess or a big mastoid cavity cholesteatoma, don't use any bone dust that is infected. Got it? So now once I have delineated, I am gonna remove this. Whenever you are drilling, the basic principle is use the side of the burr most of the times if it is possible. Not the tip like this. Don't do this burr holing. People do sometimes. Don't do this. Don't do this. Don't do this. Do this. Move. Keep moving. Keep moving. Keep moving. Keep moving your drill. Keep moving your drill. Keep moving it. Okay. Once you are doing a cochlear implant, don't go like this. In cochlear implant, you have to keep the mastoid margins undermined so that it holds back your electrode channels. Couldn't get it. What? Yeah. Is it okay? No? It's not there. Oh, microscopic picture is not going there. Audio visual. You have to fix it, no? Someone fix it, please. You don't see a microscopic picture? Excuse me? Auditorium? It is coming now? Okay, okay. So I'll further remove this bone. You have to be very smooth when you are doing. It is wobbling. Whenever your drill is wobbling like this, don't use this drill bit or do one thing, reduce the speed. It will stop wobbling, okay? So now I'll go further. So in cochlear implantation, you try to undermine it like this. Got it? You trying to undermine it so that it holds back. But I'll show you the canal down, cortical. What problem? Transmission problem, man. तो मशीन चलती है तो मशीन तो चलेगा. लेटरल स्कल बेस में पूरा जगह चलेगा. उंगली से नहीं कर सकता. It is there. Whenever I use the drill, it stops. So they are fixing the problem. Got it? Now, even after running the drill, are you seeing this? Are you seeing? Okay, now it is fixed. So I am removing this bone I am removing this air cell, or you have already started seeing the sigmoid sinus there. Can you make out? This is the sigmoid sinus. Okay. So I'll expose it further there because our intent is to do a cortical mastoidectomy there. In all cortical mastoidectomy, you should explore it like this. Remove the lateral bone, the bone lateral to sigmoid. Remove it. You have to be very cautious, control on your hands so that you don't go in there. Getting my point? And you are not drilling on a one spot. You are going, moving your burr. And then I am thinning out the posterior canal wall. Even if you are doing a cholecystoma surgery, please thin out the posterior canal wall. If you are doing an intact canal, thin out it properly so that, how does it help? It will get you the direct view inside, head-on view. And the second thing, if some recidivism, that is a recurrent or a residual cholecystoma is there, this bone will break and cholecystoma will come in the canal rather than going to the middle fossa or the posterior fossa or eroding the facial canal or eroding the labyrinth. So you are giving the cholecystoma a very thin bone to invade rather than canal than the vital structures. Getting my point? So it should be well thinned. Thin it out further, and go to the tip, lateral to the sinus, like this. The bone, pre-sinus bone, remove this. Then come to the sinodural angle. That is one of the place where you leave the cholecystoma. Because sometimes you think, I have done. Because you don't see the, right now you don't see the sinodural angle from this angle. Oh, some loose connection, please correct it. Yeah, I'm sorry for that, they are doing it. No, this is not. This is not giving. The problem is there. Whenever you are using the drill, it is going on. That means there is some loose connection, for sure. So you can do it. Yeah, and do this there. You are seeing now. So I'll go. And now it stop again. Coming. So I'm further drilling the bone and saucerizing the whole cavity. You know what is the concept of mastoid? Saucerize. Saucerize the cavity. Don't make straight lines. Saucerize the cavity. I don't know. The key in lateral skull base surgery is you should make out the change of color, the play of color. Wherever the bone color changes, you might be there on the labyrinth. It becomes pink superiorly, pinkish, sometimes blue. It is dura coming. You are at the tegmen. Posteriorly, blue we could appreciate. It is sinus. Canal down, you appreciate some pinkish structure coming. It is the facial nerve, the fallopian canal coming. Inferiorly you go, you see reddish, brownish ridge coming. That is the digastric ridge. When we do the sinus decompression right now, you will see endolymphatic sac can be appreciated as a white, creamish white out of the dura. I'll show you there. I'm not getting your voice. Look, the way I am going, can you make out the way? We can go like this. This is quite easy to remove this ridge. Getting my way? On it. Now you are seeing sound I am not getting. Can you make out I am delineating the sinus? Perisinus air cell I am taking. This is not sinus, this is air cell. The catch is I am moving my burr continuously. I am not staying back to one place. The structures which are coming, which they will lead you itself, that where you should go along the bone. Getting my point? So the structure is saying me that, yeah, go ahead. Yeah, I can't make out your question. I'm not able to. Yeah. Okay. Sure. Meanwhile, we'll wash. Give me water. Lot of water. Wash. It helps a lot. Washing helps a lot. You should have liters of saline before doing any skull-based procedure with you. Wash. Sometimes, I'll tell you, meanwhile, I'll tell you something. Whenever you are doing an enterostomy or you don't find antrum there, you are in a fix. I could not see an antrum there. Don't. It will come, don't worry. So, when you are in fix that you could not go to antrum, stop there. Go to the tegment side, dura side. Start drilling along the dura. Then go inside and anteriorly along the base of the zygoma. Then go inside there, and you will see the antrum. So when you are fixed, it could be a coronal septum. A coronal septum won't let you go inside the antrum. And you will think we have reached, but you have not seen the additus. So in that case, follow the dura. Go along the dura from base of zygoma till the sinodural angle. Go medially, slowly, you will not injure anything, don't worry. Slowly go inside and you will see the antrum. What is antrum? It is the largest mastoid air cell, and that will lead you everywhere then. Once you see the antrum, start widening it. Once you widen it, see for the lateral semicircular canal bulge. Lateral semicircular canal is the most consistent landmark in a skull base, in a lateral skull base. The most consistent landmarks, styloid, lateral semicircular canal, processes cochlear formis, Eustachian tube. These things, they are the most consistent landmarks. Okay? So now it is done. So you are seeing, Rajiv, you are seeing? Pani. So I am going till the I am further thinning out the bone, pre-sinus bone. Can you make out the air cells? The I'll go enter to it, and here you can do like this along the canal. Yeah, but in my opinion, wherever possible, use the largest possible burr, because a small burr will go in somewhere. Can you make out? I am still using it, and we can do this. We can use, and you enter the antrum there. Can you make out antrum? And you see the faint line of lateral canal. So now inside out at the zygoma, at the base of the zygoma, you are going towards the base of the zygoma. Can you make out? A dural puncture, how to avoid it? You have to be smooth. Your transition of birth should be very smooth and slow. Don't be in a hurry. If you are in a hurry, don't operate. Don't do injustice to the patient. Keep cool and calm and do operate. Okay? Know the anatomy first. So at first see the radiology. Give me a smaller burr. So you can make out the lateral semicircular canal there. Can you make out the dome anterior? Okay. Smaller. Looks like no, इससे बड़ा नहीं है, बस 3 बार है. फिर कैसे करेगा फेशियल आगे, और डायमंड भी नहीं है. हाँ, ये तो पूरा चल जाएगा. So this is not an ideal burr I am using. You should use a bigger burr because it can go here and there. Give me that one, the medium size. But burr to और चाहिए. Yeah, we require a 4 mm there. So you require all sizes of burr in mastoid surgery. Got it? Another thing. What mistake I am doing? What mistake I am making? What mistake I am doing? Crossing the instruments. Don't cross the instruments. They should be like this. Never cross them. You will be injuring something. Complications would be there. Never cross your hands. Now use this burr. If it is a bigger one, you have to use it judiciously like this. The pre-sinus bone I am taking. I am going towards sternodiural angle now. Centrifocus. Okay, done. Can you appreciate the dura there inside? Okay, yeah, this is blocked. Yeah. Fine focus? Okay, I'll do. I'll do according to you guys, then I'll focus. Is it okay? Okay. Can you see the dura there? So this is the dura with bony plate there. This is tegmen. Yeah, it is not good. Yeah, I don't know. Suction. Suction not what? Is it okay? Better now? Yeah. Suction. This is sigmoid sinus. Can you make out? So it is there, and I'll show you the jugular bulb also later on. But at first we'll do the basic otological procedures. So this is how you are at first doing the cortical mastoidectomy, okay? Also known as Schwartz mastoidectomy or simple mastoidectomy. Can you make out the air cells there? Now lateral to the adductors, if you go, you thin out this bone some more. Can you make out? I am going head on. I'll do this. कुछ मत डालो, पानी मत डालो. अच्छा तो दिख रहा है इनको. It is better, Rajiv. Is it? Look, this is this. I think this is best. I can make Rajiv here. Okay. So going further in there, I'll tilt my microscope further so that you guys can appreciate what I'll do with my outer wall of the adductors. So to see the short process of incus, you go further, and inside out you come like this. It is wobbling. It is wobbling a bit. Have you started seeing the short process there? रुक जा पानी, हाँ रुक जा कम. It is wobbling. Can you see the short process now? It is very well seen. The short process of incus. It is there in the fossa incutis. What is fossa incutis? Fossa incutis is a space there anterior to lateral semicircular canal, lateral to facial nerve, which harbors two structures, short process of incus and posterior incutal ligament. And the short process of incus is the guiding landmark for your posterior tympanectomy. Got it? So I'll further make it straight, the posterior canal wall. Look, how much can you drill the posterior canal wall? Can you make out? I'm not getting your voice, Rajiv, here. These cells I'm removing, small cells, and I'm going in the sinusoidal angle from lateral to medial. It is fusing with the dura. If you can make out tegment and try tegment mastoidica, and then going medial to it, going further medial to it, and you see some air cells. You see some more air cells there, and you can make out the posterior canal is coming in view. Can you make out the posterior canal coming in view? Yeah. What you do is, no, do this. डालो इसमें पानी डालो. बस. Some more drilling at the tip. Don't go anterior. Bas. Because your facial nerve would be coming like this and going like this. So you have to be cautious when you are there, but facial is never lateral to the level of your lateral semicircular canal, so don't worry. Can you make out the tip cells there? Yeah. हाँ. कर दो. Can you make out something there? Digastric ridge comes there. Can you make out this ridge? This is digastric ridge. Can you make out? This is digastric ridge has come. Entry to it would be your facial nerve here, going into the stylomastoid foramen. Still you have some air cells medial to it. Yeah, retrofacial cells. These are the retrofacial cells. And they communicate with what? They communicate with what? Yeah. हाँ चेंज कर दो. हाँ कर दो. ये पता नहीं कलर कैसा आ रहा है.
यहाँ में बहुत अच्छा है, लेकिन उधर में थोड़ा ये है. अब जल्दी करो यार.
कोई बात नहीं, आराम से. Communicates with the hypotympanic cells. Got it? So a few people, they propagate that when they are doing tympanoplasty, they'll just do a bit of mastoid drilling. Ice ball pattern, you suck ice ball, all fluid comes. So they suck on that mastoid air cell and fluid comes through the middle ear. They think that your adenovirus is patent. While that fluid would have come through hypotympanoretrofacial cell also. So if you want to really make out the patency of adenovirus, do a cortical. Got it? It takes 10-15 minutes doing a cortical. Okay. Okay. दिख रहा है ऊपर राजीव? बस. I'll take a smaller bulb now to show them the posterior hypnotomy for cochlear implantation as well as to see the residual disease there in sinus tympani, to clear the disease behind the ossicles. Who gave this posterior hypnotomy? Jensen gave the concept of posterior hypnotomy. Then if you want to extend it further down, you have to cut the chorda, that is extended posterior hypnotomy. So the boundaries of posterior hypnotomy, basically posterior hypnotomy is going in what? Facial recess. This is bounded laterally by the chorda, medially by the facial nerve, superiorly by the fossa incudis, or this ledge of bone which is separating posterior tympanotomy from the incus. Okay. So I'll magnify it now. Yeah. Can you see this area? Now, okay. So you can see this is incus, short process here. So in the line of the short process, you see this is lateral semicircular canal. You have to be a bit lateral to it in the line of the short process like this. So you start drilling there and you will find some air cells. What air cells are these? Name? They are known. एक minute. So you are coming in between my view. Herald cells. They are known as herald cells. Oh, it is wobbling. Can you make out how I am going? I am keeping lateral to the facial. Oh, it is wobbling, yaar. कोई डायमंड है क्या? डायमंड लिया है? हाँ, ये दे दो. So if you take a very thin, small size bud here, you can enter in facial rather. You can enter in fibrous annulus. Come in the canal. You should take a bit bigger burr and then start delineating the things. I'm removing this bone lateral so that I can come head on there. Can you make out? Now, look, I am doing. What I am doing is, I am flushing, making it round. Can you make out? Making round, so that I can appreciate the transition of bone to the facial canal. Then I drill this like this. पानी डाल दे जाए. Irrigate. I want a smaller burr. Now, at this juncture, I'll tell you something. Give me a pick. Okay. So I'll take one. Yeah. It's okay. Can you make out the area of concern? Yes, मुझे छोटा दे दो. Is it visible properly? You can make out, Rajiv, a bit of it. So you are in the cell, and then you can use a pick or a ball probe to widen this cell, and then the drill itself. And if you can make out a faint line going there, that is your chorda. Give me a small burr, very small burr. You don't have 2 mm or 1 mm. Na? This you can give me. Yeah. A bit centralized.
हम लोग मेनली ये तो कर लेंगे ना, उसका आगे इंटरनल आईओसी में तरफ जाएंगे.
हाँ. कम डालो यार, कम डालो. कम. Can you make out? Sorry, I have removed this. This should not have been removed due to wobble of the. So you can make out the IS joint there. This is your landmark. Now, if you see, you are not still seeing what? We want to see the round window that we are not seeing, but you can very well see the chorda tympani. Can you make out? Can you make out the chorda there? Okay. So now, yeah. You do have a curate, a small curate. Curate or maybe a ball probe. No, pick is there only. Okay, pick यार ये मुड़ जाएगा, खराब हो जाएगा. थोड़ा स्टडी पिक दे दे. चल ये दे दे. हाँ, nice दे. So if you can make out, this is your chorda. We should do it with the drill, just for the sake of showing I am taking it. Because just posterior to it your facial nerve. Okay? Drill it furthermore. Give me the drill. Yeah. So slow I am going. I'm pressing, I'm removing, wobbling a lot. So I'm pressing, I'm removing, I'm pressing, I'm removing. A bit of this. Yeah, now I'll see further. Give me the pick. I'll remove this and then I will come head on. This bone you can think. Now if I come head on like this, and even then you are not seeing the round window there. So you have to drill it furthermore, anterior bone and the lateral bone. So give me the diamond. Diamond, you don't have small diamonds. What I am doing is, I will take this bone a bit. Can you make out a more vertical view now? Head on view. And then you remove this bone medial to facial. I'm bounded by the size of the burr. I'm sorry. Bone anterior to the facial I am removing. And that is a safe thing. Can you make out a glimpse? Still your facial is not there, don't worry. Your facial is not there. Got it? Now your facial, can you make out some change in color there? Can you make out the change? Wash, wash, wash. So you can make out this change in color. Yeah, this color. Wash, please, wash. What hello? Can you make out this color change? This is pinkish. So this is your facial. Don't worry, I am not injured. I am removing the bone anterior to it. And inferior to it. Once I do it, now you will see, give me the pick, and you will see the round window. Can you make out round window? And this is your round window comes. Remove this soft tissue, easy to remove. It will be a smaller one. Adapter nahi hai. Adapter and chota. Oh. Yes, lateralmost part we have to remove. Then we can see it better. Now give me the drill again. Bigger drill, yeah, I'll take. So this is the posterior tympanotomy you see, huh? I'll remove the lateral part of the canal wall a bit. just to show you, don't do it in surgery, but even in surgery you can remove a bit of it. Around even up to 4 to 5 mm you can remove it. No issues with that. What is it? Is it helping me? Look, now I have reduced, now I will thin it. Thin it. Yeah, jet should not come in my way. Can you make out? You are more head on now. You are more head on. I'll do this. Yo, this again closes. I'll fix it there. देखो, ठीक है? टच किया और हो गया. सूचर से नहीं कर सकते क्या इसको उधर? Look, okay, now. So, okay, I'll show you what I'm seeing inside. Can you make out? Can you make out the round window now? पतला चाहिए, नहीं है क्या पतला? नहीं है? अरे यार फिर कैसे करेगा? Is clear now? अब मेरे पास छोटा ड्रिल नहीं है राजीव. So the anatomy I'll show you. If you guys can see me outside. Yes, show my outside picture, okay? So in this ear, how my cochlea is sitting there? My cochlea is sitting there like this, like this, like this. Can you make out? This is my round window, but my round window is like this and the turn is going like this. Got it? So this is my round window like this. So even if you open the round window, you are not seeing the cochlear duct. What you have to do is, you have to drill the anterior lip of the round window and remove the crista. What is that? Hook from the basal turn. Then you are seeing the basal turn, sinus, tympani. Got it? And above this would be the second turn, which comes in front of the oval window. So when your Jacobson's nerve goes up there on the promontory, it goes towards processus cochlear formis. So you drop a vertical line from processus cochlear formis, and from the midpoint of the round window you go anteriorly. The point where they cut, if you open there, you are in the middle turn. So the cochlea is not like this. Cochlea is like this. There. It is going like this. Got it? It is going like this. Like this. Basal turn, middle turn, superior turn. Okay? Facial is like processus cochlear formis is there. Got it? Oval window, round window. So round window is not directly projecting in scala tympani. You have to drill anterior, inferior, and anterior lip of the round window to see the cochlear duct. Okay, I'll show you that now. Yeah, suture is there. So I'm applying this suture to the flap. ये कौन सा सूचर है? 20. उंगली से दबाने का है. काट दे. यार अगर ड्रिल में बच्चों के पास होंगी ही नहीं चीज़ें तो कैसे करेंगे? So I have sutured the anterior flap, okay, cut. Now give me the smallest possible burr. Smallest burr, as such I require 1 mm there. But it will not go there, I think. I hope it goes there and does the job. Can you make out the round window? But you don't see the membrane yet. Got it? So if I drill, this is too big a drill for this. पानी कम कम डाल कम कम Oh, so there is the round window membrane. Can you make out? So if I remove this membrane, I have drilled what? I have drilled anterior lip and I have drilled the superior lip a bit. Then if you open this round window membrane, look, what is this area? This is your hook region. If you remove this, I want a stout. If you remove this, you can go for implantation. I am not able to do it very fine because of the instruments, but during live surgery I would not have done like this. Oh, it is moving. Look, look, it has moved on its own. It has become a hook. Do you have any other instrument? Stout instrument? Oh, instruments नहीं हैं. Repositor. Oh, the graph repositor or elevator. So Rajiv, they don't have instruments there. So I'll yeah, then I'll show. Yeah. So this is the window membrane. I am trying with my this thing. Oh, it is moving. It is getting bent. Yeah, this is stout. I'm sorry, your instruments. So this is your crista. Okay? Yeah. Can you make out the cochleostomy there? This is what I prefer always. Oh, don't. Yeah. Now give me the implant. So the implant is in the form of your this thing, the suture. 20 I am using just to show you guys. Forceps. Look. Direction, antero-inferiorly you go, then it moves on its own. Slowly, you go there and it will go. Actually, it is bending on its own intracochlear forceps. That crocodile forceps you do have? One more forceps? है? कोई? नहीं है? कोई बात नहीं. So still your crista is intact, Rajiv. Yeah, I'll show you. They want to see the crista. So this is crista, hook. This has to be drilled. I can't drill because there is limitation. Suction, yeah, suction. Because I don't have appropriate size burr there. Can you make out the round window very clearly? So I'm going. Okay, so you can go further. You can use two forceps. Usually the Javelier's forceps and the hook is used. They are given by the company itself. The company gives that. Centralize. Fine. So you don't use these forceps with the implant. They give you Javelier's forceps and a hook. Okay, I'm going in further and stop. Wherever you find a block, friction, stop there. Don't try to insert. You can do if you are not satisfied the whole length has gone or not, you can twist the implant a bit by 90 degrees like this. Twist it and then follow. So I'll cut it there. Give me seizures so that when we do a cochlear drill out, we'll see this implant in the cochlea. Got it? Oh, small. Small seizures है, microscopic seizures नहीं है, small seizures भी नहीं है. You have this. Oh, Rajiv, no. Do the drill out. You want me to show the drill out first? Yeah. Okay. So I'm keeping it inside. Yeah. I'll take. So I've kept the implant inside. I've left the stent. Can you make out? I've left it inside. Now, at first we'll delineate the labyrinth, see the endolymphatic sac, do the labyrinthectomy and see the IAC and come out. Then I'll do the external canal excision of the lateral canal cancer, lateral temporal dissection. Then we'll do the mastoid job and facial nerve decompression. Yes. So थोड़ा fast कर दूँ. चलो. अभी कितना बजा है? 3:15 हो गया. Oh, give me the diamond bar. नहीं, ये है मेरे पास है. क्योंकि ये तुम्हारा वॉबल कर रहा है तो मैं डायमंड से ही करूँगा. अब थोड़ा मेहनत तो लगेगा, लेकिन अब क्या करूँ? ना कहाँ फास्ट हूँ बस. अब तक तो I would have done this. Yeah. So now what I'll do is I'll remove all these cells. These are retrofacial cells. Can you make out? Pani. You see the facial going there? This is intercanal facial decompression. You can do like this. Okay, intercanal facial decompression. Can you see the facial there? Very well. These are retrofacial cells. Put it there where I'm doing. रुक जा. Can you make out the facial? So this is intact, Rajiv. So intercanal facial decompression, when you do, you can do this. And you You see the chorda? Can you see the chorda there? I'll show you like this. I'll show. The chorda arises around 6 mm proximal to the stylomastoid foramen. Can you see the chorda there? Very well seen. Okay. So you see the chordofacial angle there. Okay. Now my purpose is not to show facial right now. My purpose was to delineate this area, to show you the whole labyrinth. Some more retrofacial cells are there. If you go further, yeah, these are still air cells, Rajiv. So I am making a facial bridge. Can you make out? I am leaving a facial bridge there. Intact facial bridge technique for jugular, for glomus. Yeah. Okay. So you leave this facial bridge and go medial to it, like this, so that you reach to the hypotympanum from here, like this. Oh. मुझे बड़ा वाला दे दो अब चाहे से. हाँ, बड़ा सेक्शन. हाँ, निकाल दो सारा, मुझे चाहिए चारों. मुझे डायमंड चाहिए था अच्छा सा. Can you see the jugular bulb is coming in view? Pani. Can you, don't you feel it's so wonderful to see that how many cells are there? How many cells are there? Look at it. Look at it. Retrofacial cells going in and in. Can you make out? Yeah, so it is infralabyrinthine, retrofacial infralabyrinthine approach you are going towards the petrous apex. Yeah, towards the petrous. Now you can see the blue thing. What is that? That is your jugular bulb coming. Honey, point all. Yeah, that's true. That's true. No, glossopharyngeal cannot be seen until you remove the lateral wall of the jugular bulb. You can't see. It is medial to the medial wall of. At first, you will encounter the inferior petrosal sinus, plug it, then drill further, remove the medial wall. After obliterating the sigmoid sinus proximal part, then you will see the nerves. Oh, I'll show you all the nerves. Don't worry. Yeah, IJV you tie in the neck and sinus blockage. Yes, infralabyrinthine approach. So this is infralabyrinthine approach, okay? You see the jugular bulb? You can appreciate. I'll stop there now for quite some time to show you the endolymphatic sac. Okay, Rajiv? Rajiv? Yeah, you are seeing this? Okay. So I'll come now. I'll focus on the labyrinthine block. So further drilling to delineate. Pre-sinus bone you have to remove, and you leave this eggshell bone there on the sinus. Sometimes you leave an island of the bone that is known as Bill's Island, in the name of William House, the great man who has given the concepts of lateral skull base, ear surgery as well. And why Bill? Because his friends used to call him, "Hi Bill." William Will? No, Bill. They call him Bill. "Hi Bill, how are you, man?" So that's why they have given it a Bill's Island. And in the interacoustic canal, above the transverse crest, there is a vertical bar which differentiates, hold it, which separates the facial of the superior vestibular, now known as Bill's bar, that you have to preserve when you are doing a translabyrinthectomy approach, so that your facial is preserved, because facial is anterior and you are going from posterior. All this bone can be removed. Yeah, there are cells. This is your superior canal, which is coming in view. Can you make out? It is coming in view. So whenever you do have a superior semicircular canal fistula, dehiscence syndrome, you can go two ways to block it, and they do have a conductive loss. Vertigo, pulsatile vertigo, pulsatile tinnitus, and a conductive loss. So you should get a Porcell's view on MR, a Porcell's view on an MR and CT, which is a lateral view cutting through the external canal, parasagittal view cutting through the canal, and you will see that the superior canal is dehiscent somewhere. So the two approaches are there to block, to cover that defect. One is middle fossa approach, middle fossa, mini craniotomy you do, go along the tegmen inside, see the canal, obliterate it a bit, cover it, that's it. Or you can go under saline, underwater dissection. You fill it with water, go with a small bird there, and then you can see that and obliterate it. Okay? Don't obliterate, cover it. If you obliterate, it is going to give further vertigo. Can you see the superior canal now? So this is the superior canal. Pneumatic. Yeah. Connect. So this dot which is coming, what is this area? Subarcuate artery, also known as Meigs dot. When you go there, lateral canal, superior canal, and you come to this area which has got a depression, it is giving you subarcuate artery known as Meigs dot. Got it? It bleeds. So you use the diamond drill and job done. Now, a solid angle I'll show you, don't worry.
एडजस्टमेंट देख लीजिए एक बार।
हाँ।
तो आगे दिखता दिखेगा।
अब ठीक है?
नहीं, आप यू आर कंफर्टेबल ना?
I am comfortable.
Okay.
Oh, so I'll reduce it to 0.6. Oh, it's better. So you are removing the bone, pre-sinus bone. Can you make out? Yeah, can you make out? I am exposing the posterior fossa dura now. So you are seeing the posterior fossa dura. So now if you see the lateral canal and make an imaginary line that is known as Donaldson's line, which cuts this posterior canal into, and here just posterior inferior to that you will see the sac. I'll show you that. I'll go a bit. Yeah, you can already see. Rajiv, you have got third eye. Okay. So if you lower it further, for that, Rajiv, I have to decompress it further. I'll do this at first. I have to decompress the sinus. Still I want to decompress the sinus, so that your IAC should be seen better. Now diamond, yes, here diamond, on the sinus diamond. Even if your sinus injures, don't worry. Use a bipolar, or a gel over it, or a bone wax. So I can compress it a bit, leaving the Bill's island there. No pressure. Pandalo. So now, if I press it, I press the sinus, look, and can you appreciate this whitish structure which is coming in view? Can you appreciate this whitish structure? This is your endolymphatic duct. Got it? Very well seen, Rajiv? Huh? Okay. So I'll move it further down and I'll incise it. We'll do endolymphatic sac decompression. And it is a very good procedure for resistant cases of Meniere's disease and saving the hearing as well. Okay? Can you see this fold? Whitish fold which is coming? So this is your endolymphatic duct and sac going fishy. And on CT you call it vestibular aqueduct. On CT you call it vestibular aqueduct. Live surgery open you call it endolymphatic sac. So aqueduct is a bony space which is harboring endolymphatic sac. So you call it dilated when it is more than 2. Yeah, posterior fossa dura. Yo, look the sac. Look the sac. Okay, I'll use a knife. Open this, look. This is endolymphatic sac. Can you make out easily? And I open it like this. Look, I have opened. Yeah, one dura, the outer dura and the inner dura. Can you make out? Can you make out it is going inside? Look, it is going. Okay? So this is endolymphatic sac decompression you have done. Okay. Now we do labyrinthectomy. Okay? So what are the superior and inferior limit for interlocustory canal? Inferiorly cochlear aqueduct will come. Superiorly is your dome of superior semicircular canal. So I'll delineate the canals first. How do you do that? Go along the canals like this. Fine. Give me cutting board, yeah. Hard bone. Labyrinth is the hardest bone in the body after the enamel. Dental enamel is the hardest, toughest bone. Second is the labyrinth. Oh, इतना बड़ा नहीं, छोटा, थोड़ा छोटा है. अभी बीच का सा लाए थे ना 4 बार, 4 बार लाए थे ना, बॉस ने दिया था 4 बार. Yes, diamond. Yeah, individual canals. I am taking a no. अंदर खोमची में रखने का है, बचाने का है. हाँ, काम का है.
काम के टाइम पे देने का.
Okay. Okay. Can you see the posterior canal? Open. You see the lateral canal? Yeah, ये section, ये दे दो. So this is what I am doing, labyrinthectomy. This way only you should do, okay? This is the ampullary end, this is the non-ampullary end. Ampullary end, non-ampullary end, got it? And superior semicircular canal. Can you make out? Can you make out easily? So that is your superior semicircular canal. You can see posterior canal, lateral canal. Okay? Then if you drill here, you see the crus commune. कम पानी डालो यार. You see? Pani. You see? And this is your crus commune coming. Can you make out easily? Okay? So look, crus commune. Non-ampullary end of superior semicircular canal and your this posterior semicircular canal, they join at the crus commune. This is the ampullary end of posterior canal, ampullary end superior, ampullary end lateral canal. Now do you drill this whole structure, and you can make out the facial there. Can you make out facial? Very beautifully. Okay. So I'll do the labyrinthectomy now. Oh, sorry. The diamond drill again. I'll take it a cutting, body cutting देना, बीच वाली cutting. Any doubt? No doubt? Good. You should have doubts. I am there to solve all your queries there to the best possible knowledge I do have. Okay. Now I will be doing this labyrinthectomy. Can you make out something? What is this? This is your? No. Your vestibule is opening now. Anteriorly is what? Saccule. That is your neuroepithelium. Can you make out neuroepithelium? Can you make out the neuroepithelium? Reddish. I'll show you on higher magnification. Can you make out this neuroepithelium? Red. Okay, this is neuroepithelium there in the saccule now anteriorly, and this is your vestibule posteriorly. Look, your vestibule, can you make out? Vestibule is open. You can even see the epithelium inside. Rajiv, appreciable? Yeah. You always keep this lateral bone intact so that your facial is not teared off at the first genu, because it is at jeopardized on the first genu. It is making an angle of around 120 to 150 angle, more than that. So if you remove this bone right now, your facial is going like this and like coming like this, okay, in the canal. So it will break the continuity. So keep this lateral bone intact and then remove this further. Can you see? Very well seen vestibule and all. You don't have a smaller burn, huh? Now you are working on the superior trough and inferior trough of the internal acoustic canal. You do have two troughs, superior trough, inferior trough, and you have to drill 670 degree. Got it? This is neuroepithelium I am removing. Can you make out? Neuroepithelium. And this is the whole utrico-saccular complex. Can you make out? Easily? Yeah. Yeah. Change. Lateral, yeah. Obviously, facial is lateral.
Even shape is put by that.
Yeah. Still it is going Mike's dot. Subarcuate artery. Can you make out this artery? But this is saccule, vestibule, utricle, sorry. Utricle, saccule. And this is subarcuate artery. Go further and you are going there. Got it? Now, drill this whole bone. Can you make out? Tubular structure comes in view. Here, your cochlear aqueduct will come. I will show you. Can you make out that? There is structure. I will cut it. And you will see it is cochlear aqueduct. Look, this is the cochlear aqueduct open there. This is the air cell, and over here, look, this is the cochlear aqueduct. Rajiv, can you appreciate? Can you appreciate this? Rajiv? Yeah, cochlear aqueduct. Yeah. I'll make it. Can you make out now? Yeah. Yeah. It makes your two things. Cochlear aqueduct should be opened. Why? First, to decompress, so that CSF will leak out. CSF will leak out, and you can press the posterior fossa and middle fossa. So you get more space. So you have to open it and leave it for some time. CSF will drain out. Second thing, it makes the inferior boundary, inferior trough. Over here, it is in there. Can you make out that point? Inside, yeah, the white one entered to that. Can you make out? Yeah, yeah, it is merging there. So now, I will be opening this. This is your I am removing this bone all around up to 270 degree. I will take a cutting bar now, because it's very difficult to use diamond on the labyrinth here. Cutting bar. Oh, smaller than this. Hey, I do have this. Now I'll shift my microscope further. We can remove it, leave it. My microscope will go like this, and my yes, porous is deeper, fundus is lateral. Look how much space you are getting, huh? Neurosurgeon boss, how much space you are getting. Look, you can remove any acoustic from here by the trans lab, I am telling you. Huh? अच्छा ये लो अब ठीक है So this is your superior trough. You can see the middle fossa dura, and now what comes in view? Superior petrosal sinus. Can you make out whitish structure? That is your superior petrosal sinus there. Can you see the superior petrosal sinus condensation? Yes. Yeah. You are going like this is translabyrinthine approach. One is superior labyrinthine approach. You go there. Infralabyrinthine already I have shown you. We can make a bridge, or we can, what do we do? The facial can be dislocated anteriorly. You can mobilize the facial anteriorly. Okay, and then the medial wall medial to facial drill, you can go infralabyrinthine, you can go supralabyrinthine. Approaches to petrous apex. There are a lot of approaches. Eagleton's approach and all those names you do have, supralabyrinthine, infralabyrinthine approaches. Can you make out this tough bone? I'll show you. Can you see the nerves there in the canal? I have enjoyed a bit of the dura. Because of this burr, I am not happy. Look how entirely I am going, huh? Around 270-degree exposure should be done. Pani, pani, pani. Now, give me the diamond now. Yeah, you have started seeing the nerve there? Oh, I'm sorry. I'll do it on point 4. Now, you can see the interacoustic canal open. I'll show you. Let me drill the bone around it. I'll show you everything there. Oh, why it is going on its own and it has to be increased. Oh, no, the
Light.
okay, it's good now. Water, please, water. So, sir, you see the middle part, and we are showing you the lateral part, sir. We are showing you the lateral part of IAC. Can you make out this IAC? This is interacoustic canal. Now, the fundus, got it? You go from here and you see the medial part, CP angle. We are showing you the lateral part. From here, if you keep on going, you see the dura there? Oh, no. Can you see the canal now beautifully? Patla. You guys are able to see, na? Yes, I'll orient you. I can't get you guys there. Wash. Yeah. I'm going 270 degree. Got it? You have to open it 270 degree. What nerves you are seeing from back? Superior vestibular and the inferior vestibular. I orient. Let me finish my 270 degree. That is a rule. Okay, almost 270 I have got now. This also, some more. Now, I'll open the dura now. Okay? At this stage. Someone please take pictures also so that we show them. So this is the dura. You can make out the dural with the arachnoid. Got it? So I open this. Look. Upside. Got it? And down there. Can you make out? CSF is coming. Look, CSF started coming. Can you make out the whole neural bundle? And now, if you see, I'll show you on a higher magnification. I'll show you on a higher magnification that you do have a plane there in between the superior and inferior vestibular nerve. Can you make out the color change a bit? Can you make out? I don't know you guys are making out or no. Can you make out this? This? Mind focus karu? It's good? So you separate it. That is superior vestibular nerve. Look, and if you retract, can you see this? Facial comes. Got it? Your facial comes. So you have to use a hook and cut it. Okay? When you want to do a vestibular nerve section, just hold it and cut it. A part of it like this. Got it? It is cut. And now you see the facial. And what bone? What bone is there? Yes. So if you go up there,